Hello, welcome all. We'll get started in just 1 minute.
Good morning. Good morning, ladies and gentlemen. Good morning, dear fathers, dear sisters. Here we are in the second roundtable hosted by the Dicastery for promoting integral human development and its partners. And we will address the issues of WASH, so water, hygiene and sanitation in Catholic healthcare facilities. This roundtable is only in English, and there will be time for a dialogue at the end of the roundtable. In the meantime, please do not hesitate to share in the chat box who you are and where you are based. It will be enriching, a way to share, a way of know each other. The meeting is being recorded chiefly for internal purpose. So we do not expect to put it online, but just in case, you can always switch off your webcam. My name is Tebaldo Vinciguerra. I'm an official of the Dicastery, and here with me I have several wonderful panelists, plus also a wonderful support team. Many of them are based in the US, and they deserve my big gratitude for being with us really in the middle of the night. Without further delay, we will introduce now the topic of WASH in healthcare facilities with the voice and the expertise of Giovanna De Meneghi. Giovanna De Meneghi serves with an Italian NGO called QAM, Doctors with Africa. The NGOs is based in Italy, headed by a priest, and they send doctors, nurses, and technical staff to support healthcare facilities in Africa. Giovanna De Meneghi has field experience in Mozambique as well as in Sierra Leone. Giovanna, please, you are our first speaker. Let us dive into the challenges posed by WASH in healthcare facilities. Giovanna, you have the floor.
Thank you very much, Tebaldo, and good morning all. Good morning, good evening, good afternoon, depending on the time zone. So I'm gonna share my screen so that we can start with the presentation. Discussing with Tebaldo, we tried to focus mainly not just on the health facilities per se, but on the context of working on health facility and WASH in a wider and more difficult situation, especially when it comes to climate change and conflict areas. Because my experience in Mozambique was actually this one, starting as country manager for Doctors with Africa QAM in Mozambique in 2018, the situation was pretty much easy, let's say. So we were calling Mozambique a development, a country with development activities. But starting from March 2019, we started to be hit by intense cyclones that then posed way more difficulties. And then we also had been experiencing a conflict in the northern part of Mozambique in the province of Cabo Delgado. So I wanted to integrate those different concepts within the idea of working in a safe environment at health facility level. So let me start with a very, let's say, rhetoric question, which is it possible to live without access to water? And obviously the answer is no. And Mozambique is not an exception. Indeed, according to UNICEF, only half of its population have access to improved water supply, and less than a quarter use improved facilities, sanitation facilities. And of course, this differs between urban and rural area, with the rural settings experiencing the worst situation. Well, let's start from the very beginning. What's Mozambique, where it is located? I saw that some colleagues also come from Kenya or are based in Kenya, so I guess they're more familiar. Mozambique is in the southern part of Africa, is around 3,000 kilometers long, which makes a very huge country with very different context. It comes, it became independent in 1975, one of the last countries to reach independence from Portugal. But then it entered in a very dramatic civil war between 1977 and 1992. It has a population of around 30 million. And again, like all those data bring to understand why Mozambique is still the 180th country out of 188 in the Human Development Index. As I was saying, Mozambique was mainly considered a developing, let's say, in terms of activities, country up to March 2019, when the first cyclone Idai hit Beira, the central area of Mozambique, destroying, killing more than 1,000 people, leaving plenty of displaced people. We still don't know how many, and disappeared as well, and destroying plenty of health facilities, but also houses, schools, and the city of Beira mainly. And the last cyclone we had, still in the same area, was Cyclone Eloise, which hit Mozambique, still the same central area of the country, this year on the 23rd of January. So this is just to give you a perception that working in a system that is resilient is essential. However, it's not that easy to find a situation and a country ready to respond, because this was the first time ever that 4 cyclones hit one single country in less than 2 years. And this is those are some of the pictures. And this is the health facility where we work. This is Pontagea Maternity in the center of Beira. So again, when it comes to wash, and this is Beira, this is the surrounding area of Beira, unfortunately. When it comes to wash, having a resilient health facility is essential. But at the same time, why is it essential? We will see in a minute. Another very challenging situation we are facing in Mozambique is the kind of civil war that has not been declared so, but internally we refer to the attacks of the insurgents in the northern province of Cabo Delgado as an insurgency that started in 2017 and brought about 700,000 people to flee from the northern districts towards the southern ones, and then entering the province of Niassa and Nampula. And just to give you an idea, in Mozambique, there are plenty of key voices that have been talk about this issue and also work around these issues. We are talking about the humanitarian world, like the NGOs, the UN, but also the church. And since we are talking in this momentum, it would be interesting to underline, and I always try to do so, that the voice of our Don Luis Lisboa, who is the former Brazilian bishop of Pemba, which is the capital city of Cabo Delgado, was one of the most prominent one, and also the Pope spoke about this issue. And I mean, this is just, sorry guys, but just to give you a situation, an overview of the situation and how the intensity has become kind of unsustainable at the moment. Why am I saying so? Because health facilities, the population, the government is not ready to receive more than 700,000 people more in the southern part. And this is the reason why we are trying as QAM to support the government and the health facilities where we work to be ready to receive a wider amount of people and a wider amount of cases again, why, after this brief introduction of the country, why WASH at health facility level is essential? According to WHO, healthcare associated infections contribute to morbidity and mortality and to a loss of health sector and household resources worldwide. 5 to 30% of patients develop one or more infections during a stay in a hospital, and a significant proportion of which could be avoided. Again, of course, in some situations, in some cases, the situation can be worsened, and this is experienced especially when we have additional difficulties. In this case, the situation of having a cyclone that destroyed partially or entirely a health facility, a worse situation where health facilities are not accessible, but also a situation where endemic diseases such as cholera or diarrhea explode again. So this is the reason why having a safe environment and supporting the health facilities to structure itself and to be resilient to every kind of difficulties they may face is essential. So which are the key requirements for having a functioning healthcare facility? Safe and sufficient water, basic sanitation, adequate management of healthcare waste, appropriate knowledge and application of hygiene, and adequate ventilation. Of course, all of them are essential to reduce the various healthcare associated infections, because within a health facility, and we have been seeing this especially in the Western world where we are not used to it with the pandemic of coronavirus, is that health facility can become the place where viruses are vehiculated. In other countries, such as I'm talking about the country I know the best, like Mozambique, it is a way more, it happens very often that you have a situation where a health facility is inundated by water and has like small water rivers that became bigger due to the rainy season that brought about more mosquitoes, which sometimes means more malaria, but also possibilities again of outbreak of cholera and diarrhea. So working on reducing those infections by improving the facilities is essential. And some of our activities as a QAM was actually not just to rebuild a health facility as it happened with the cyclone Idai, where we actually rebuilt 4 maternity wards and 3 health facilities and the full newborn care department of the Central Hospital of Beira, which is the second biggest city in the country. But it also means to start and supporting the health facilities staff in having an adequate behavior, not just as a staff, but also as patients. And this is the reason why we have been working. This is some of the places where we work. This is the health facility within the resettlement sites in Cabo Delgado. And those are the resettlement sites, again, just to give you a perspective of our work at the moment. And those are the pots I was talking about. Again, those pictures were took by our colleagues in Mozambique in the site of Metuj in February. And this is a situation people face. So it's not just a matter of working with the health facilities as an institution, but also with the people. And starting with the strong sensitizations. And this is one of the other activities we are doing on improving WASH at community level, which means also having a direct effect on the health facility level. This is one of our activists, which we call like a community-based activist, trained on basic wash practices, but also in recognizing possible diseases such as malnutrition, diarrhea, cholera, and they go household, in this case it's not household, but is tent by tent, giving cholera kits, giving basic hygiene information, and also directing all patients to go to the health facility in case of a suspect disease. This is essential because otherwise you risk to lose lives in the camps without having or overcrowding a health facility with diseases that can be prevented and that can be treated also at community level. So the commitment is a joint commitment between the community activities and the healthcare facilities, both on a clinical base, but also on a wash base. And those again are some of the key sensitization activities that we have brought about.
Please, Giovanna, you have 1 minute to conclude, please.
Yes, and again, the additional, let's say, difficulties that we have been having this year all over the world were also coronavirus. Therefore, it was also mainstreamed as an activity in all our sensitization activities. And this is it. Health is a right, fighting to respect it is a duty. Obrigada.
Obrigado. Thank you very, very much, Giovanna De Meneghi from QAM, Doctors with Africa, for opening with your first keynote or roundtable dedicated to WASH in Catholic healthcare facilities. Again, this is a roundtable promoted by the Dicastery for promoting integral human development and its partners. Now we will ask to Global Water 2020, which is an initiative based in the US, and it has been a partner of the Dicastery in this endeavor to share brief video of 3 Catholic voices. So a representative from the Dicastery, from Caritas Internationalis, and the Vatican COVID Commission. So please, dear Lindsay Denny, thank you very much.
Access to water and related hygiene and sanitation should be a cause that unites the whole human family as behind a universal priority. Nowhere is this need more critically felt than within a healthcare facility, especially in a labor unit and in a delivery chamber. None of us, my dear friends, will wish to receive health care in a hospital or a clinic without clean running water, without toilet facilities, and without soap or disinfectant. Yet, nearly 2 billion people worldwide have no choice but to receive health care under these badly compromised conditions.
As someone who ran a children's hospital for 10 years, I can tell you all the medicines in the world will not keep children healthy without access to clean water. Without clean water, there is no possibility of adequate health care. Not to have clean water when people are most vulnerable increases the risk to their very lives. This is not a new problem, and it has been a cause of the spread of diseases, as well as the inability to get them under control. We must challenge a world that can create systems to live in space, build high-tech machines and buildings, but does not put that same genius to work providing clean water to millions dying for lack of it.
Access to good health and hygiene depends on access to clean water. This is also among the most important lessons we have learned from COVID-19. Improved sanitation has significant impact not only on health, but also on social and economic development, more particularly in developing countries. We could also drastically reduce child malnourishment and help alleviate physical and mental underdevelopment. Deliver resilient water and sanitation services and be part of the change needed to leave no one behind.
We must not be patient, as the lives of children and families are threatened and consumed by the daily challenge to find clean water. Never mind that even in their healthcare facilities, they are not assured of clean water.
Thank you. Thank you very much for this video and these inspiring comments, Sister Keehan. Thank you, Mr. Aloysius John and Cardinal Peter Turkson, for your voice and your guidance in this. I will now briefly present the initiative promoted by the Dicastery. And again, I greet all of you and welcome you once more. I've seen in the chat people joining us from Kenya and Uganda. These were countries involved in this initiative. Greetings also to colleagues from Malawi, Australia, Myanmar, and even in the heart of the night from the USA. So in 2018, the Dicastery hosted a major international conference in Rome about the management of water as a common good. And we had two outcomes of that conference. The first one was publishing a document. It is the Aqua fons vitae document, which is available online. It was published last year. The second idea was inquiring about wash conditions in a sample of healthcare facilities. So we studied the feasibility and the opportunity of having a new assessment tailored for Catholic healthcare facilities. So in August last year, Cardinal Turkson sent a letter to all bishops of all the countries, asking them to be aware and to take care of wash in healthcare facilities and also in schools. Where we perceived an interest, an answer, then a training was set up with the help of Global Water 2020, of the Caritas Confederation, and also with some partners such as QAM, so you just heard Giovanna De Meneghi, to train local staff for this assessment. 150 healthcare facilities received a very detailed assessments about water quality, deliveries, toilet, hygiene, soap, and so on. This assessment included hospitals and small dispensaries in urban setting as well as in rural areas, healthcare facilities belonging to dioceses or to religious congregations in 23 countries, chiefly in Africa, but also Haiti, the Philippines, and Albania. Where we had problems or specific challenges in getting the assessment done, then technical support was available by phone, and in a couple of circumstances, even experts traveled abroad to assess themselves those healthcare facilities. So now we will share the results of this assessment. This is not representative as the whole healthcare facilities of the Catholic Church, but it is simply showing the situation in areas where the directors of the healthcare facilities, the sisters, the doctors working there by themselves ask to be assessed. So perceiving or knowing that there are some shortages and need for improvement. This said, I will now give the floor to Ms. Lindsay Denny, so Health Advisor at Global Water 2020, and she is also a Program Associate in a Global Safe Water Sanitation and Hygiene Program in Emory University. Please, Lindsay, you have the floor.
Thank you very much, Tebaldo, and it's a pleasure to be here with you all. I'll go ahead and share my screen for this presentation. Oopsie, excuse me, for some reason my mouse is being a little bit wonky. One moment. Let's see if I can do it now. So I'm presenting on the results of the assessment of water, sanitation, hygiene, and healthcare facilities. And as Tebaldo said, this assessment was undertaken with support from CRS, as well as with Caritas. So to first just remind us all, as we've heard already today, this is a global challenge, and it's not unique to only Catholic healthcare facilities. Globally, WHO and UNICEF found that 5 in 10 healthcare facilities lack basic water services, 6 in 10 lack basic sanitation services, and 3 in 10 healthcare facilities lack hygiene services at points of care. It's worth noting here that this information is fairly recent. We are only really understanding the scope of the problem, the magnitude of the problem in the last several years. And so this assessment by the Catholic Church is illuminating the problem not only to understand amongst the orders and dioceses, but also to help the global community better understand the issue. So as Tebaldo mentioned, we did assessments in a sample of healthcare facilities in low and middle income countries. And it was conducted by dioceses, congregations, and bishops' conferences, some of which are here on the call today. So I thank you all for your support in helping make this happen. We certainly could not have done it without you, and we know how challenging during COVID it is to collect this information. So there was 140 assessments. Tebaldo mentioned 150 facilities. There were a handful of facilities in Uganda that had previously been assessed. So we didn't redo the assessment. We did include them in the initiative and the follow-on costing estimates. About a fifth of the facilities were hospital facilities. The rest are health centers, dispensaries, health posts, what have you. And the facilities reach 28 million people in providing healthcare services and span across 23 countries. These assessments were collected between December of 2020 and February of 2021. They take about 45 minutes to do, and if you're interested in the assessment tool, we will be sharing it around. It is something that if you did not get your facility assessed, you're welcome to use. And the status of the situation is being shown as of March 2021 when we did the analysis. So as I look at the data, I do want to reemphasize what Tebaldo mentioned here. This is a snapshot of conditions, but I would say it very much aligns with what we're seeing in public facilities. So there is some level of representative information here, but again, this is only 140 facilities. So please keep that in mind when looking at the data. So basic water services, the information and the indicators used are based on what WHO and UNICEF have defined for these service requirements in healthcare facilities. So for water, that means that an improved water source is on premises and is available at the time of survey. An improved water source is one that's protected from contamination. So that would be an example of like a borehole. Wanting to make sure that it is available at the facility, on the facility premises, and that when they're there doing the assessment, you can turn on a tap or go to the borehole and water is accessible. We found that 63% of facilities lack basic water services. And of this, one of the major issues is the accessibility of water on premises. While many facilities have access to an improved water source, it's often available not on the facility site, meaning that someone at the facility has to go walk, collect water during the day. And this impacts over 25 million people visiting these healthcare facilities. This is a quote from one of the surveys. Water is the main problem for our health center. For more than 8 months, water has been unavailable. The hygienist or the cleaner goes every morning to a well located more than 500 meters from the center to fetch water with cans. And if you can imagine the role of a nurse, a midwife, even a cleaner at a healthcare facility, they're incredibly busy trying to provide safe care. Walking back and forth to collect water is really not the best use of their time. And thinking about how much water you'd be willing to spend if you had to go collect the water, I'm sure they're particularly judicious in their use. Then we look at basic hygiene services, and the WHO and UNICEF standards says that there must be water, hand washing facilities, either soap and water or sanitizer at points of care, meaning where patients receive health care, and then water and soap within 5 meters of toilets. We found was 53% of the facilities assessed lacked basic hygiene services. And between the two, one of the biggest issues was around soap and water available at toilets for both staff and patients. Again, this impacts over 22 million people. And we think about COVID, we think about our concerns about hand washing and ensuring proper hygiene. It is critical that soap and water are available throughout healthcare facilities for staff, certainly, as well as the patients. Another quote from the assessment: health workers are routinely not able to wash their hands due to insufficient water. And actually, of the 10 facilities assessed in the Democratic Republic of the Congo, all 10 had this response in the specific diocese. So certainly a challenge. And then finally, we look at basic sanitation services. And this is a complex indicator. There are 5 parts. And the first, the toilets are available to patients, and these toilets must be available, functional, and private. Toilets must be accessible, so at least one toilet is available for people with limited mobility. So you think about someone, a pregnant woman or someone in a wheelchair visiting the facility. There must be at least one toilet for staff that's separated. Toilets must be sex separated, and then some toilets must be equipped with menstrual hygiene management facilities, in which case that's a bin and a waste disposal, as well as a private place for washing. And this is where we see the largest issues. 90% of facilities lack basic sanitation services. Of this, 74% lack menstrual hygiene management, and 63% lacked disability accessible services. And this impacts nearly the entire catchment area. So over 27 million people visit facilities that do not provide basic sanitation services. Of these major issues I mentioned, disability accessible services is really the most costly of things to fix here. You would need to have probably new construction to make sure a toilet is disability accessible, where menstrual hygiene management is a relatively low cost improvement. And I do want to note that globally, this indicator is, as it's in its complexity, is something that's just now being collected by countries. So actually, we have very limited information in public facilities of the situation. So really, the Catholic Church leading the way here on data to tell us what the situation is on the ground and the realities of what these facilities are working with. We also look specifically at facilities that provide delivery services. So 90 of the 140 facilities provided delivery services. And we asked a couple critical questions to understand the challenges they faced. We asked them whether pregnant women were expected to bring their own water when they came for delivery. And 15% of the facilities that have delivery services said that sometimes or always women had to bring their own water. And WHO recommends that 100 liters or 25 gallons of water is used for a safe delivery. And that's for before, during, and after all the various activities that need to be undertaken to ensure infection prevention and control. 100 liters, that's about a bathtub's worth of water here in America, is certainly far too much for a woman to carry with her to the facility. So you could imagine that some of the practices that need to be undertaken cannot because there is insufficient water. Similarly, we asked where running water and soap are available within the delivery rooms. And 1/5, 20% of the facilities did not have running water and soap on the day of the survey. So again, thinking about the best practices, ensuring that midwives and doctors and nurses are able to wash their hands, critical, particularly in a delivery room. One of the last questions we asked, and this was certainly added on at the end, we had made this assessment before COVID had hit. We wanted to know whether facilities were starting to address wash conditions in response to the pandemic. And it was heartening to see that 84% of facilities said they had made some improvements. And as we think about prioritization of wash and why this has been such an issue over the years, I think it is certainly something to build upon, that facilities recognize the role wash plays in infection prevention and control and the safe delivery of healthcare services, even if they don't necessarily yet have the budget to make all the improvements that this assessment has pointed out. So after doing the assessment, we undertook a costing estimate of the facilities. And out of the 151 facilities as part of this initiative, we received 108 estimates. The total average facility request was $64,000 US, and the median request was $58,000. So extrapolating for that, we estimated $9.7 million is needed to make improvements to make sure these facilities are up to basic wash standards based on WHO and UNICEF guidelines. I just want to bring around a single country highlight here. We have a couple colleagues on here that were part of the Kenya assessment, so I thought I would focus on that. In total, Kenya, we had 29 assessments, of which 10% were hospital, 90% were non-hospital facilities. 7 out of 10 facilities in Kenya lacked basic water services, 4 out of 10 lacked basic hygiene services, and 8 out of 10 lacked basic sanitation services. So following along, maybe a bit better than what we saw globally in some cases, a bit worse in others, like the water situation. In total, $2 million was requested, on average $82,000 per facility, and would reach facilities, reach over 700,000 people. I do want to note that these requests for costing include 3 years of operations and maintenance, these requests come from the bishops' conferences. So as a follow-up to all of these assessments, the facilities received a report that talked about the strengths and issues that need to be repaired or addressed, as well as a decision tree to help facilities start to identify solutions. In addition, we're working with the Dicastery to identify potential partners to help start funding these issues, and then providing a list of potential funding opportunities to facilities to apply to separately to get support to start making these improvements over time. Expecting that will be an incremental improvement. I doubt we'll go from 0 to 100, but starting to build upon progress to reach basic services. And I will, just a note here about climate resilience. We know that that's an incredibly important part of this, and this past week was Laudato Si. So just a note that as we build back better, wanting to make sure that all facilities are climate resilient, and that we are building systems that are risk-informed and addressing some of the issues that we heard earlier from Giovanna. So if you have any questions, please feel free to email me. My email is on the bottom or part of that Zoom link that you were sent. You can also reach out to Tebaldo at this water email. So Tebaldo, I'll hand it back over to you.
Thank you very, very much, dear Lindsay, for this excellent overview of the recent assessment. As you explained, but I want to underline it once more, all this project was designed after a conference which took place in 2018. So all this was before the COVID-19 disaster. So COVID gave additional visibility to this very, very, very challenging situation. But the weaknesses, wash weaknesses, were already there obviously before COVID, as we know, as you know from the field. And then I greet colleagues from Burkina Faso, from India, from Papua New Guinea, and many representatives from Caritas agencies in Asia. Thank you very much for being with us. Laudato Si has been mentioned. Indeed, in the recent days, we had the so-called Laudato Si week. And precisely, maybe some of you knew it, but precisely the event that took place on Monday, this was the 6th anniversary of the encyclical letter Laudato Si, so that very event was dedicated to WASH in healthcare facilities. Now I will ask Sister Alfonsa Kiven from Cameroon to share about her experience. So she is a Franciscan tertiary sister with a robust experience in healthcare, and currently she is in the headquarters of her congregation. So here in Rome, she will share something about WASH and related challenges. So dear Sister Alfonsa, welcome. Thank you for being with us. Do not hesitate to share your screen if you need it. So you have some 8-9 minutes. We will go a little bit beyond the expected deadline with the wonderful dedication of our colleagues in the US that are in the middle of the night. Sister Alfonsa, please, you have the floor.
Thank you very much, Dr. Tebado. I would first of all like to thank the Dicastery for this initiative, as well as those who have organized this webinar. Good morning, good afternoon, good evening. From where you are, I would like to share my screen. Share the screen.
We can see your screen, Sister Alfonso. If you want to.
You can see my screen?
Yes, but it is not the PowerPoint.
Okay.
Yes.
Perfect.
Okay. So. Start this. Okay. I am Sister Alfonsa from Cameroon, based here in Rome. I'm a tertiary sister of St. Francis. The Tertiary Sisters of St. Francis run many health facilities in Africa. We run 4 hospitals, 13 health centers in Cameroon, 1 health center in the Central African Republic, 2 hospitals and 1 health center in Nigeria. We also own a cardiac center for the whole of the Central African region. We run facilities belonging also to the various dioceses, especially in Cameroon. And water scarcity hinders effective healthcare services in these facilities, as you have heard from the previous speakers. Hospitals have pipe-borne water from catchments, which often dry up in the dry season. Many of our health centers are in the rural areas where water scarcity is crucial. People have to walk many kilometers in search of water, which at times is not safe water. Our facilities are partially equipped for the delivery of babies, though some have no taps with running water in the delivery rooms, and water has to be carried in containers in the delivery rooms. The effects of COVID-19 in these health institutions. At the outbreak of COVID-19, the Cameroon government designated 2 of our hospitals as treatment centers for COVID-19. This was and is an added problem to the already existing and critical challenge of scarcity of potable water. Water is being rationed at the present moment. It's difficult to wash bed sheets, floors, and toilets. And this is a risk of infectious diseases. The lack of sufficient water for wash has actually hindered the effective combating of this pandemic. We have several positive cases that are tested every day, both from the staff and the doctors. An additional critical situation is the effects of the civil war going on at the moment. People who are escaping from the effects of the ongoing civil war in the Anglophone part of Cameroon seek refuge in our hospitals. So the crowd running into the hospital with no protection have added to the crisis of the COVID-19. We have recorded many deaths. Having sufficient water and toilet is one of the biggest challenges. So the situation at the moment is very, very critical because many displaced people come to the hospital, there is no check, they just rush in, no water to wash. We are afraid of the moment of outbreak of other diseases like cholera because we don't have sufficient water for these people crowding into the hospitals and in the health centers. So our urgent needs. Considering that 70% of the running costs of these facilities comes from fees from patients, many who cannot pay. And in order that the initiative of the Dicastery and its partners be effective, the Tertiary Sisters of St. Francis, as well as other congregations working to provide health care in poor areas would need financial assistance and in some cases, technical assistance from donor organizations to provide potable water, boreholes, or wells, especially in rural areas where access to it is a fortune. Personnel protective equipment, e.g. face masks, hand sanitizers, gloves, disposable gowns, are one of our greatest needs at this particular moment. I want to say that when the government created these health centers, these hospitals as treatment centers, they didn't provide what was needed for hygiene and the protection. So this had to be borne by the sisters. So we also need to train some people to supervise our water sources, water reservoirs to preserve and supply water in times of scarcity. We need technical assistance for cost estimates, for designing and implementing adequate wash solutions and equipment. The Tertiary Sisters also run a rehabilitation center And here you can see patients with physical disabilities fetching water from the only borehole that we could afford. And in this case, we don't have water inside the wards for the patients. They have to go out with their containers to carry water, which we cannot say hygiene is saved here. Just show you some of the pictures. We have the dentistry. You see here inside the dentistry, there is no running water. They have to carry water in the container. And so many other wards. So the effect on the cardiac center. The tertiary sisters own and run the only diagnostic cardiology center in the whole of Central African region. This year, with the climate change, we have suffered the worst water crisis as the main water catchment got dry very early. Because of the severe dry season, the water catchment really ran down, and this disrupted some of the activities that could be carried out in the cardiac center. We cannot risk to start operations of patients if we don't have enough water. So this year has been very, very critical for us. So I just show you how the cardiac center looks like. We try to give joy, especially to children and their families who have lost hope. This child just came out of the operating theater and was a miracle. The child started smiling. Our aim is to give hope, a smile on the face of many who come to our health centers like this beautiful child. Thank you very much. I invite you to visit our website. You will get more about us because in 5 minutes, I cannot talk about 6 hospitals, 23 health centers all over the world and all over Africa. This is just to give you a taste of what we are and what we need. Thank you very much.
Thank you. Thank you very, very, very much, dear sister. It was a wonderful test indeed. The Dicastery is working to support the healthcare facilities involved in the assessment and looking for technical assistance and donors and also support for training. This is absolutely necessary in several poor areas, such as the countries or the needs described right now also by Sister Alfonsa. On the other hand, the Dicastery is not planning to do more assessment and to expand in other areas. What we want is more to have some kind of snowball effect or to inspire action. So the tools for the assessments will be shared, partnership will be encouraged, and the Dicastery will give more visibility and facilitate further contacts, knowing that to some extent, these issues didn't receive enough visibility in the past. WASH in emergency was well covered. Water, human right to water is well covered. And healthcare also was well covered. But WASH in healthcare apparently didn't receive enough attention, enough funding, enough support. So I have seen a couple of comments in the chat box. Do we have some question that could be addressed by our panelists? Any comment? As I wrote in the chat box, we still have 2 voices to inspire us, to guide us. But in the meantime, do we have any question? So I will leave more time for the questions if you want to think about your questions or to write them. And in the meantime, please, Lindsay, if you can share this testimony from Father Rodolfo Vicente Cancino, also known as Father Dan. So he is the executive secretary of the Bishops' Commissions for Healthcare in the Philippines. And again, if you have questions or comments, do not hesitate to write in the chat box. Please, Father Dan Vicente.
The assessment done regarding WASH in our health facilities has revealed three important points. First, it was really a shock for us really to see the WASH condition in the water and sanitation services is really deficient, all pointing towards a potentially overwhelming burden to contain really the virus.
We need really to focus our next steps on the adequacy of water availability. Second, the acceptability of water quality. The third would be water resource management must be increased and an affordable access to water, sanitation, and hygiene. I hope that this message, not coming from me, but really coming from these communities and from the hearts of all those people who are doing their best to stop the pandemic and to bring quality of lives to the community. We have been known a people of resilience and persistence. And we get that from our belief that we cannot do it alone. Impelled by the love of Christ, we can do it together. We here as one.
Thank you very much, dear Father Dan. This was a simple and powerful testimony. Together we can do it, and certainly it is needed that we do it together. The Dicastery will host other roundtables, such as this one, with different voices, different panelists, but again, it will be other roundtables around WASH in healthcare facilities. So if some of your colleagues or someone in your network would like to share also this experience and to learn from the Dicastery's assessment, later today, we will have one roundtable in French, and tomorrow, one in English and one in Spanish. This said, I've seen a question about displaced people. So here in the Dicastery, we have a special team working precisely on migrants and refugees. But this said, I don't know if one of the panelists has a brief comment on WASH and health assistance to displaced people, but knowing that the core of our roundtable is WASH in healthcare facilities. So in the end, the question is those displaced people when a massive number of them reaches outnumbered or outstaffed Catholic healthcare facilities. Sister Alfonso, please.
I could say something about displaced people and water. Also about refugees, because our congregation, because of the war, have opened a community to care for refugees and displaced people from Cameroon. It was very difficult, but with the help of our donors from Germany and from the US, we were able to have boreholes in some of the camps for the displaced people and refugees. Of course, they are in their thousands. This is just a small group. It is very difficult for these displaced people. But we have tried with the help of donor organizations to provide some help. This is what I can say.
I've seen a question about the kind of challenges that were revealed or assessed during the assessment. So many different challenges. So all this info is very well, let's say, organized. So with a good database per country and per diocese. So we can quite easily tell what kind of problem has been observed in that specific healthcare. Another view was given by Lindsay Denny. I don't know, Lindsay, if you want to give some additional information about the diversity of the problems, maybe, or some situation that especially worried you, Lindsay?
Sure. And I think this is a question that came up earlier this week as well. What is sort of the root cause, essentially, of some of the barriers to ensuring safe wash? Why has this become a problem? And one that we're just now putting such emphasis upon. And I think one of the major challenges is that wash is not prioritized, is not seen as essential. When you think about all of the other things that a healthcare facility has to pay for, thinking about essential medicines, thinking about treatment. Unfortunately, though we know that wash is important as a public health measure, in a healthcare facility, it doesn't necessarily have the prioritization that other, other very important issues are being funded. Some of the challenges that I found concerning in particular were around issues of operations and maintenance. So this is to say that many of these Catholic facilities did have wash when they were originally built, but they aren't necessarily maintained over time. In part, again, thinking about who runs a healthcare facility, they're not wash experts. So having the proper capacity within the facility, having the knowledge of when there's a problem, who do you go to, how do you maintain it, is something that we're seeing not only in Catholic facilities. This is a global problem. So I do see a lot of similarities. I think certainly the biggest difference here, and something that is an opportunity to address these poor conditions, is the authority of the Catholic system, Catholic health system, to oversee their facilities, to use the system of the diocese as supervision and accountability mechanisms to help support these healthcare facilities to make these incremental improvements and maintain them over time. So it's really building in that capacity.
Lindsay, can I just ask a follow-on question from that? I guess just thinking about a lot of these communities where the assessments took place, majority would not have access to any wash facilities in their homes, certainly not in their homes, and most often not in their communities. And did you encounter any particular challenges, or whoever did the actual physical assessments around the prioritization of wash in healthcare facilities versus also the basic human rights of wash in communities as well?
Interesting. That's not something that we've seen as such an issue. It's more of an issue amongst our WASH colleagues in terms of prioritizing their response of how do we do healthcare facilities without doing the communities. Well, we're of course do the communities. That's never an issue, but you can't ignore the healthcare facility as a pillar of that community, as in providing services. I have not encountered an issue amongst the population making a similar concern of having that issue. It's more from our perspective of how do we divvy our prioritization and limited resources. But I think when we think about the healthcare facility, and when you visit these facilities and talk to the doctors and nurses, they know this is a problem. Yeah, we don't have water. It's an issue. But they're doctors and nurses. Their skill set isn't to bring that to the facility. And so it's how do they have partnerships with those who are able to provide that, that I think is one of the biggest challenges. And how do we start to bridge two very different sectors, the health sector and the WASH sector, to start talking to each other and start budgeting and accounting for these issues. But at the same time, to your point, Bernice, is to bring in the community as a key stakeholder. What does the community think would be valuable to prioritize initially? Oftentimes these healthcare facilities have community health boards that are run by community members that make decisions on budgets. So they are very potentially very powerful allies and powerful stakeholders in this and can't be overlooked.
Thank you very much, Bernice, for these questions. The idea of having, let's say, a focus on WASH in healthcare has been kind of really the desire of the Dicastery of giving special visibility on that very issue. If you have a look to the document Aqua fons vitae, which was, I mentioned it earlier, it's much more wide. So the Holy See very frequently promotes the human right to water, to sanitation, and underlines the duties. So if you have a right, then there are duties for the state, for the community, for business, etc. Yet we decided to have this focus on WASH. And if you visit, maybe later, the action platform for the Laudato Si that has been launched yesterday, we will see that in this action platform we have several goals. And one of the goals is response to the cry of the earth, to the cry of the poor, ecological economics, and so on. And in that context, the Dicastery will promote WASH, but even beyond healthcare. It will be something bigger. The Dicastery and its partners, among all, obviously, the Caritas confederations, are working a lot on this issue. So do not hesitate if you have some more specific on human right to water versus other issues, do not hesitate. About sharing the tools, they will be shared using the website of the Dicastery very soon. And technical assistance also, we are trying to understand who can help in this specific context. Among us, we have also representatives of CRS or some other Caritas here with us. So it takes time to create the good partnership, especially when you are usually working on WASH as a challenge for emergency earthquakes and battlefields. Then you need to change a little bit everything. So from donors application to evaluation of application to transparency, we are working to promote this kind of change and improve the collaboration from the Dicastery. Now I have the pleasure to give the floor to a citizen of Italy that then moved far, far, far in the night in the US. Thank you, Dr. Anna Serra, for being with us. So you represent, well, tonight, the International Catholic Committee of Nurses and Medical Social Assistants. You also, let's say, a very experienced nurse in the US, so member of the US Catholic Nurses Association, and in a hospital in Connecticut, you're also the vice president of that hospital. So very good understanding of the challenges of nurses and medical assistants in the context of healthcare. Please, so Dr. Anna Serra, you will give us final inspiration. You have the floor, and thank you for being with us.
Thank you, Dr. Vinciguerra. It's my pleasure to be here, and thank you for showcasing the CCMs. And I am a member of that committee. And basically, our goal is to assist Catholic nurses globally by providing evidence-based practice. Next slide, Lindsay. So disclosure, that's just a common, I don't have anything that ties me to that. So next slide. And the focus of my presentation will be on basic hospital planning. As Dr. Vinciguerra said, that is my area of expertise, if you will. Hand washing to prevent COVID, as we've heard other presenters speak of this today, and other information that will be provided to you in the reference section of the PowerPoint. Next slide. Together, one team. I mean, many of you, like me in Connecticut, in the US, we were the epicenter. We got hit hard and furious, like a tsunami with COVID-19. We went from having a 5-bedded ICU to 30 beds very quickly, all respirators. We could not have done it if we didn't work as one team. Next slide. COVID has been a global challenge, as you all know, and we've heard a repeated common theme, hand hygiene. Washing hands, I guess it's a commodity for those that have water, and we've heard others, Sister Alfonso, speak of the lack of having that where she is. But certainly throughout the COVID and having PPE equipment has been a challenge. Definitely to protect each other and to keep it safe. Having masks and availability of gloves. Social distancing, it goes without saying, they say 6 feet or basically 2 arm legs. And certainly the whole vaccination that's happening now to achieve herd immunity. Next slide. Communication. I can't say that enough. Communication. I'm part of the Yale New Haven Health System in Connecticut. And basically, as a leader, among my other fellow leaders, we had to lead. We listened. We empathized with our frontline staff. We had to learn very quickly to be more agile. And we had to take risks. We knew that perfect was not an option. It was not a necessity. Good had to be good enough with what we had and what we were able to get our hands on. We had to trust at all levels. Our bedside staff had to trust the leaders. We communicated with them every day. We were visible. We had to be fully transparent, and we had to convey confidence, and we had to be honest above all else and speak the truth. Next slide. This is one of my favorite slides, and I think it's one of the most important slides in the hospital program planning and the framework, if you will, and the components. We had to quickly assemble a team and have a team leader. We basically developed a hospital labor pool and one at the system level in nursing. So as the chief nursing officer and a senior vice president, I was instrumental in leading a team of nurses, and we basically hit the ground running. Conducting an assessment was easy. We knew that PPE equipment was scarce. We developed an incident command center, both at the hospital where I work and at the system level, and there was constant communication each and every day. Setting a risk assessment and priorities, we knew our private commodity was our staff. We had to keep them safe. And how do we do that? We developed a plan. We had daily huddles, both at the system level, at the hospital level, at the unit level. We had town hall meetings to communicate. We couldn't do enough of that. We had to convert inpatient beds and put them in outpatient settings, because when we got hit hard and furious, we had to protect the non-COVID patients. Everybody was screened coming in. Everybody was tested in the emergency room, because we knew the conversion of the second floor, which is the critical care floor, and the medical surgical floor, which housed all our COVID patients. We knew those that tested negative had to be protected. We canceled all elective surgery. We basically had a rapid deployment of technology. What I mean by that is we quickly got untouched monitors. That way, the COVID patients that were in the rooms, we had the ability from outside the room with the technology to basically, listen to the patient's lungs. I mean, the technology was really absolutely phenomenal. A lot of our patients, as many of yours, they died alone in the hospital, and we had, with the surgery being canceled, those nurses that were not, medical surgical nurses, they were basically buddies with the nurses in the critical care units. And they basically FaceTime with the families. They prayed with the family at the bedside, and they held their hands, when they took their last breath. It was really a beautiful thing to see, but certainly it took a toll on our employees. And then, of course, the lessons learned, and how do we continue to monitor those improvements? Winston Churchill has a quote: "Never let a good crisis go to waste." And we're better prepared now. Rather than being reactive, we want to be proactive, and I think we've done a great job as a system. Next slide, Lindsay. So this is just a slide that depicts this, slowing the spread of the COVID-19. You have to wear a mask, and you have to wear the mask appropriately. Again, social distancing and hand washing. Next slide. And there's another slide that depicts the 6 feet. It could also be at 2 arm lengths. And everyone, I believe, globally is practicing that. And we are still wearing the masks, even though the CDC, they've lightened, the requirements of what you can do. If you're in a meeting, you're in a room, and everyone is vaccinated, we don't have to wear the mask. But if we're in patient areas, we have to continue to wear it. Next slide. And this was an example of the signage that we used. We had yellow tags on the floor to depict the 6 feet that, we had to be separated. And of course, every patient that either came into our emergency room, and during the COVID-19 crisis, we stopped all visitation. As I said earlier, the nurses became the family of our patients. But we had this both in English and in Spanish, for people to read. Next slide. No. Another one, Lindsay. Next one. There you go. So stop the spread of germs. I mean, we heard it repeatedly. For those that don't have the water, you need the water to really, truly wash with soap and water. And it has to be for at least 20 seconds is what the CDC recommends. And of course, if the water is not available and you have gel, that's certainly another option. Next slide. And this is just another picture that depicts on how when you wear a mask, I see people all the time that the mask is underneath the nose. I watch TV and I see it. It's got to cover the whole nose and mouth because, the virus is airborne. Next slide. And then, of course, I have a bad habit myself, and I really had to train myself, as I'm sure others do. When you're wearing the mask, you can't touch your eyes, your face, your nose, any parts of your face. And certainly always washing hands in between and/or gelling. Next slide. So here, how and when to wash. We heard Lindsay say earlier at the point of care, before you touch that patient, you are going in, washing your hands or gelling. Certainly after you leave the patient's room, you're doing the same to protect yourself and others around you. Before you eat, I mean, it makes sense. If you've been with a patient or you've rendered any type of care, you've got to wash your hands. And again, if there is no soap and water, then gel is the other option to use. And certainly, soap and water is the best protection. It goes back to Florence Nightingale, who was the first infection preventionist. Washing your hands will halt any type of infection. Next slide. And this is just a quote from Augustine de Noia that reads, cheer, heal, and sanctify the sick, and send down your blessings on all who care for them. As the healer, Jesus Christ our Lord, amen. Next slide. So basically, there's some videos that any of you can tap into. I put it on this slide and also in the references in the last page, just for more information, if you will. And thank you. It's been an honor being here and really learning from you all and WASH and really seeing the difficulties that are out there globally that everyone is facing.
Many thanks, Dr. Serra. When you described your slide about planning, this echoed one of the questions of Bernice from Australia about the challenges. The assessments revealed that in several healthcare facilities, the budget is not considering WASH. So even the way you design your cost estimate for the year to come, something is lacking. So even this is the step before fundraising, but just the way you plan it. I repeat, so the Dicastery will continue this work, especially to have technical support and financial support for all the healthcare facilities assessed, but also try to inspire and to create a kind of coalition of goodwill to support others that would like to do their assessments, to fundraise, to improve, and to establish technical or financial partnerships. From the Dicastery, a big thank you to Lindsay Denny, Stephen Hilton, and the Global Water 2020 team. Thank you very much, Giovanna De Meneghi from Quam, even if you are no longer with us, and to all the speakers that send their video messages. Thank you, Sister Alfonsa Kiven, and our wishes for your congregation. Thank you, Dr. Anna Serra, for your commitment and the motivation you shared. We will have, I repeat, later in French and today and tomorrow in English and Spanish other roundtables. The Dicastery remains at your disposal to continue this discussion. Thank you very much for everything, and let's do it together, as Father Dan from the Philippines suggested. Many thanks. This is the end of our roundtable, and the registration team can interrupt the recording. Thank you.
Thank you very much, all.